Hello, everybody. I'm Joanne Bargman, and I'm going to talk to you about some of the cases that I have encountered over my many years of treating lupus and lupus nephritis, and some very important lessons that I've learned that are not really in the textbooks. Dr. Mejia has already given an excellent lecture about the specifics of treating different types of lupus nephritis. And I just want to talk to you about many of the important lessons that I think we can all learn. Here are my conflicts of interest. And let's start with this first case, which is really more is not better. True story, this is a young woman who was socially isolated, a long history of lupus with multiple flares because she wasn't adherent to her therapy. She didn't show up to the lupus clinic for over 2 years. And it's important to know that almost in all cases, if your patient doesn't show up to clinic, it means they're not taking their medications. After that 2-year period, she presented to the hospital very sick with a severe flare of her lupus, including lupus nephritis. She was treated with immunosuppressive therapy and seemed to do well. And then she was discharged to my renal rheumatology clinic that I share with a rheumatologist. So we saw her in follow-up in our combined renal rheumatology lupus clinic. And this turned out to be her discharge medications. She was discharged from hospital on prednisone, 20 milligrams twice a day. Okay, sounds good. Also, Myfortic in induction doses, 1,080 milligrams twice a day. Also, Plaquenil or hydroxychloroquine, 400 milligrams daily. Plus, Ramipril, 2.5 milligrams daily in an attempt to reduce the proteinuria, the heavy proteinuria that he had. Plus, her lipids were elevated, so she was put on atorvastatin, 40 milligrams a day. Plus, because she had some hemolysis, folic acid, plus iron, plus a proton pump inhibitor, plus Septra for PHAP prophylaxis. Plus, she was noted to be tachycardic in the hospital, so she was put on a beta blocker, 12.5 milligrams twice a day of metoprolol, plus vitamin B12, I don't know why, and of course, calcium and vitamin D. So she showed up at our clinic on these medications, and I added up in this young, non-adherent patient that she was discharged from hospital on 30 tablets a day. After her visit with us, she was no-show once again for follow-up appointments, and then sometime after that presented to another hospital with acute chest pain and died. And I don't really know what the cause of the death was. But I think there's a very important lesson here. We know from the hypertension literature, from all other kinds of literature, that the more medications and the higher number of tablets that you prescribe for your patients, the lower the adherence. So really, we should strive to minimize the number of medications that we put our patients on, especially if they are non-adherent. And this is where really better is the enemy of good. So don't worry about the hyperlipidemia in the first instance. Don't worry about trying to reduce the proteinuria with ACE inhibitors, which anyway, and forget about the vitamin supplement. In fact, sometimes if we have a patient who isn't very adherent and they have a flare and we want to treat it, we will give them one 50 milligram tablet of prednisone and nothing else and say, you've got to take this one tablet every day. So I think that's an important lesson. Keep it simple. Here's another patient I have, and this is a phone call I get way too often. I have a patient, says the caller, with lupus nephritis who was treated with MMF and isn't getting any better. Should I use rituximab? What's the problem with that phone call? First of all, they just talked about MMF, didn't even mention if they were on any other medications, such as the all-important corticosteroids. Were they on a lot? Were they on a little? Was the patient taking it? And the second issue with this phone call is that the patient isn't getting any better. How long are we talking about? Not better after a week, not better after a month, after a year? Do we know that they're taking their medications? So that's the problem with these kinds of phone calls. In terms of improving from the proteinuria, it takes a lot longer in many instances than you think it should. This is one study from the Toronto lupus cohort where they looked at resolution of proteinuria in patients with lupus nephritis. And you can see that there is a slow but steady increase in resolution of proteinuria, but please look at the x-axis, number of years since the start of the proteinuria. And you can see that we're talking about up to 10 years on the x-axis. Here's another study from Gabriele Moroni in Italy that also looks at the timeline for resolution of proteinuria, just to show you that this is not a Toronto-specific issue. And you can see, again, if you look at the x-axis, that we're talking about years and years for resolution of proteinuria. And in my experience, as is shown in this particular study, that membranous lupus in the solid lines sometimes takes even longer than proliferative lupus nephritis to resolve the proteinuria. So lupus nephritis and the proteinuria is not minimal lesion disease. It can take months to years for the proteinuria to resolve. So you should get comfortable with the idea of residual proteinuria, which could either be because of fixed damage or because it's just taking a long time for the basement membrane to resolve its deficits, and don't escalate therapy because of the proteinuria not resolving altogether. It takes a long time. The next thing I want to emphasize to you is that not everybody who presents with lupus needs a kidney biopsy. This is another non-adherent patient who was lost to follow-up and again presented to the hospital very sick with an acute flare of her lupus, lots of blood and protein in the urine, elevated serum creatinine, very active lupus serology. And the nephrology consultant, not me, but another consultant, wanted a kidney biopsy. And for the life of me, I can't imagine why. But anyway, no surprise, the biopsy showed acute proliferative lupus nephritis. Unfortunately, the patient was sick, the patient was hypertensive, there was bleeding from the biopsy site, which culminated in a perirenal hematoma. The patient had to go onto hemodialysis for the acute kidney injury, so a line was inserted for that. Unfortunately, the patient developed Staph aureus line sepsis with bacteremia, which seeded the perirenal hematoma. So now the perirenal hematoma became an abscess, and the patient developed septic shock and died. And I think the main cause of this was an unnecessary high-risk kidney biopsy. So really, I think if a patient presents with explosive lupus, either the first presentation or a flare of the lupus, and has lots of blood and protein in the urine, do they really need to have a kidney biopsy? Whether it's class 4 or class 3 or a mixture of them, what you know is that it's lupus and it's bad. So if it's a high-risk biopsy, which many of these patients are, they may be thrombocytopenic, they may have elevated bleeding time, they may be hypertensive, that it's really not worth it just to confirm your suspicion. You need to trust your clinical judgment, especially if you're putting the patient at harm or at risk by doing an unnecessary high-risk kidney biopsy. Another instance is, what if a patient presents with another manifestation of acute lupus, such as lupus pneumonitis or cerebritis or whatever, and is going to be getting intensive immunosuppressive therapy anyway for those other manifestations of lupus. Why do a kidney biopsy at that point? Because you're committing the patient to intensive immunosuppression anyway. So when should a lupus patient have a kidney biopsy? I think on the whole, it is more valuable around a decision to decrease immunosuppression rather than to increase. And that might be someone who looks like their lupus is getting better, but their proteinuria is getting worse, or their creatinine is getting worse in this context, and you really don't know what's going on. And to rule out other causes of renal involvement in lupus, such as a patient who has antiphospholipid antibodies, and you're wondering whether their renal lesion could be a thrombotic microangiopathy rather than an immune complex mediated lupus disease. So that is a good theoretical reason, although in the latter case, in the patient with antiphospholipid antibodies, they are typically thrombocytopenic, they may be on anticoagulation, and that itself may be too prohibitively high risk to do a kidney biopsy anyway. But like I say to my colleagues, why do you want to do a kidney biopsy? You know this isn't going to be amyloid. You know this isn't going to be IgA nephritis. This is going to be lupus nephritis. So don't do a high-risk kidney biopsy, especially in the face of an obvious diagnosis. And like I said, biopsies may be more informative around a decision to decrease immunosuppression. Here's another patient of mine, quite fascinating, but again, I learned an important lesson here. Young woman who post-therapeutic abortion developed a lot of symptoms, alopecia and weight loss. And here's her lab work. She had very positive lupus serology, anti-DNA antibodies, decreased complements, but normal kidney function and blood and protein in the urine. And she had a kidney biopsy, which showed class 3 lupus nephritis. Not too surprising, a pure class 3 lupus nephritis. She was treated with conventional immunosuppression and did fine, except that she developed an urticarial rash, which the dermatologist thought was a drug reaction, and that the most likely drug was MMF. So that was changed to azathioprine. She did very well on this treatment. Her lupus serology normalized. It's a good sign when the hemoglobin comes up, the albumin increases, and she underwent a slow taper of her prednisone. And really, I was very happy with how she was doing. She presented with a pure class 3 lupus nephritis, and she had a very good response to immunotherapy. And I thought we were really set, and she was on the mend. And then all of a sudden, out of nowhere, she got the abrupt onset of swelling everywhere, associated with a rapid fall in her serum albumin and almost 13 grams of protein in the urine. And her serology, which had normalized on her immunosuppressive therapy, was still normal. And all of a sudden, she had this severe nephrotic syndrome. So we didn't know what was going on, and we did another kidney biopsy, and the class 3 lupus nephritis was gone, and now she had pure lupus class 5 membranous nephropathy. Same patient. And here's her electron microscopy, just showing all the hallmarks of lupus membranous GN. So this was really fascinating, and we bumped back up her prednisone again, put her on a calcineurin inhibitor, and again, over the next few years, she showed a gradual improvement. But it really brought to mind that membranous lupus really acts like a different disease. Here she was on immunosuppressive therapy. Everything was getting better in the classic way from her proliferative lupus nephritis. But really, all of a sudden, she had this pure membranous. And, you know, a lot of these patients with membranous don't show decreased complements. They don't show elevated anti-DNA antibodies. They typically do have positive ANA. So that's why it's important when you see patients who it doesn't occur to you that they might have lupus, because they don't have any rash or adenopathy or arthralgias, and they just have pure nephrotic syndrome, that it is worthwhile to still do an anti-nuclear antibody because they may have the membranous variant of lupus nephritis presenting as a pure nephrotic syndrome with no extrarenal manifestations of lupus. So this is a different disease. It's associated with better renal survival than the proliferative lupus nephritis. Interestingly, in this particular study from over a decade ago, about a third of patients transitioned from membranous to a proliferative nephritis. Whereas in my patient that I just showed you, she transitioned from a proliferative to a pure membranous lupus nephritis. And in this particular study that had long-term outcome of patients with lupus membranous, the predictors of worsening kidney function included tubulointerstitial atrophy, which is, of course, is always a predictor, persistent very high proteinuria, not going into remission, and of course, non-adherence may be an issue here, and transition to a proliferative lesion. So it's not really clear how to treat membranous lupus. As I showed you, my patient developed membranous lupus while still on immunosuppression for her proliferative lupus nephritis. There's very little evidence guiding us in the treatment of membranous lupus. There was one trial that is quoted a lot from Frank Austin that looked at patients with membranous lupus, and they were on 3 different therapies. But it was alternate day prednisone plus or minus intravenous cyclophosphamide in the NIH protocol, or prednisone plus a calcineurin inhibitor. But importantly, these were all alternate day prednisone therapies, which really doesn't have a lot of traction now in terms of treating glomerular lesions. But what they found is kind of interesting because even though the rate of remission with cyclophosphamide with cyclosporin in red was higher than that in cyclophosphamide in green or in blue, in fact, when the patients stopped their cyclosporin, they were much more likely to relapse. And this really speaks to what we see in so many of the primary GNs, that cyclosporin seems to work to reduce the proteinuria, but it only works for as long as you use it. And when you stop it, it relapsed. And that's what Austin encountered in these patients with the membranous variant of lupus nephritis. This was a study that looked at different immunosuppressive regimens in membranous lupus nephritis. Again, it's about a decade older, but in this meta-analysis, steroids plus another agent, and there were a bunch of different second agents that were used in this, was associated with a higher rate of either complete remission or partial remission. But again, this is not a trial, this is just an analysis of other reports. What about using lower doses or no doses of corticosteroids? This is the study of rituximab that came out of the United Kingdom that looked at patients getting rituximab for different kinds of lupus nephritis. They got maintenance treatment with MMF. They did get corticosteroids at days 1 and 15, pulse methylprednisolone, which went along with the pulse rituximab. But after that, they were not maintained on oral corticosteroids. So this is not really truly a steroid-free regimen. It's just that they had no maintenance oral steroids. And this was the regimen that they used. Again, they did receive a methylprednisolone pulse at the same time that they got their rituximab. There was an overrepresentation of membranous lupus compared to other cohorts, but in fact, there were a substantial number of patients with proliferative lupus nephritis. In this example, you could see that there were a significant number of patients with class 4 or lupus nephritis. And by 52 weeks, about half the patients were in complete or partial remission with this low steroids or no oral steroid regimen that employed rituximab. So coming back to my patient, what is the lesson here? I think the best treatment for the membranous variant of lupus is not well established. Most authorities, such as the KDIGO guidelines, recommend directed immunosuppression for the membranous variant of lupus only in those with nephrotic range proteinuria or declining kidney function. So, for example, if you had a patient with membranous lupus, normal renal function, and a gram of protein in 24 hours, maybe just monitor their blood pressure, things like that, but don't give directed immunosuppressive therapy for those particular manifestations. And I've shown you from my patient today that it appears to have a different kind of pathogenesis or mechanism compared to proliferative lupus nephritis. The next lesson, for me at least, is that patients will lie. And they will lie to you, and they will look you in the eyes, and they will lie to you. So this is a lovely 25-year-old man who presented with lupus and nephrotic syndrome at another hospital, had a kidney biopsy at this other hospital, and had a mixture of class 4 and class 5 lupus. He was nephritis. He was referred to me, and he got better. There was a slow taper of his corticosteroids, and his kidney function came back down to normal, but he still had very significant proteinuria. And he had another flare very quickly. And in fact, if someone has a flare very quickly, you got to wonder about non-adherence. Anyway, he had a flare very quickly after that. He was restarted on prednisone. His MMF was cranked up to induction doses again, and he just didn't get better. He didn't look like he was taking his prednisone, but he swore to me that he was taking his medications. He was sick, he was swollen, and then one day he developed severe chest pain. He went to the emergency department. His troponins were elevated. And in fact, this 25-year-old had an acute non-ST myocardial infarction, and he was admitted to the coronary care unit. I guess maybe all of this brought home the scariness of all of this and the danger of all of this to the patient. The attending physician, a cardiologist at the CCU, came to see him, and as soon as he walked in the room, my patient said to him, "I've never taken my lupus medicines, never." So the cardiologist called me up, and it was really an important lesson for me. So this brings up this idea of resistant lupus nephritis. And what I want to say to you is that I think the number one cause of true resistant lupus nephritis is non-adherence. The patient is just not taking their medication. And I think this was not really emphasized enough in the original iteration of KDIGO guidelines for lupus nephritis. And what they said was, for resistant lupus nephritis, consider a repeat renal biopsy. If they were on one drug, use another drug. If they were on the other drug, use another drug, and so on. No mention about looking into non-adherence of treatment. So really, I think one of the major causes for non-response or resistant lupus nephritis is non-adherence to therapy. And think about this: if the serology is not improving, the hemoglobin should start increasing. That's one of the things that improves the fastest. And if it's not improving, if the serology is not improving, if, like my patient, the patient doesn't look Cushingoid at all, and if the patient can't immediately tell you how many tablets of prednisone they take every day, then I don't think they're taking it. Because if they're prescribed 5 milligram tablets, and let's say, for example, they're taking 40 milligrams a day, that means they've got to count out 8 tablets every day. So they should be able to tell you right away that they're taking 8 tablets of prednisone. And if they can't tell you, I suspect they're not taking their medications. So I publicly spoke about how KDIGO has to get its act together and really address the number one cause of resistant lupus nephritis. And happily, in the revised guidelines, issue number 1 is now that you should verify adherence. If you're lucky enough, you can check the myfortic or MMF level or infusion records if they're on cyclophosphamide, things like that. So I think that's really important. And the lesson here is that the commonest cause of resistant lupus nephritis is that the patient is not taking their medications. So how do you increase adherence to therapy? I wish I knew. I think many patients are not told that lupus is a life-threatening disease, such as my young man who didn't take his medications until he had a heart attack, and I think that was a big wake-up call to him. I tell my patients that having this is just as bad as being diagnosed with cancer. I emphasize they don't have cancer, but they have something that could kill them just as much as cancer. And they have to take their medications. And just like a patient who has to take cancer chemotherapy, there will be side effects to treatment, but they have to do it. And they will come out at the other end in better shape. If you don't tell patients that they've got a potentially life-threatening disease, and they take the medications and they get a little nauseated or their cheeks get a little puffy, they may say, oh, I'm not doing this, and stop the medications. So it's really important that you have to emphasize to them that lupus is potentially a fatal disease. So I think that adherence to therapy is a much bigger problem in lupus than we know. So keep the number of medications to a minimum, like I said before. You can contact the patient's pharmacist, see if they filled their prescription or if they've gotten any refills of their prescriptions, but don't take it personally. But your patients may swear to you, look you in the eye, swear that they're taking their medications, but actually they're lying. So be prepared for that. So these are some of the important lessons that I've learned in my journey of treating patients with lupus nephritis. Just to recap, most patients are young and they're not used to taking a whole lot of pills. So keep it simple. It takes a lot longer for resolution of hematuria and especially proteinuria than you think. This is not minimal lesion disease. I don't think a kidney biopsy is necessary at presentation or at the time of the flare, especially if a patient is at high risk. I think membranous lupus is a whole different animal compared to the other types of lupus nephritis, and I think the optimal therapy for it really hasn't been discerned yet. And finally, non-adherence to therapy is probably much more common than we realize. And thank you very much for listening to my talk.